I've sent a reminder invite just 15 minutes back, so that if people have forgotten, it was a reminder for them.
Yeah, you did that, correct. वैसे Saturday evening is a bit,
yes, sir.
Saturday evening थोड़ा मुश्किल है, right?
I thought this is the best time for audience.
That's true in some ways for some people, yeah. Even 5 of us is good enough to discuss here. We can have fun amongst ourselves.
No, but Dr. Dinesh wanted to address Dr. Murthy. Is he here?
He's going to join in shortly, sir.
We crossed 25 already.
Join.
You started process? Nobody else has come? Delhi there.
Okay. We crossed 30.
Yeah.
One, like the COVID figures are going up.
Okay. Just for the audience, we are waiting for people to join. We are giving 2 more minutes.
Once we reach 40, we'll start.
No, sir, we could wait, sir. People want to listen to you.
40 enough, Irma.
Good.
We may reach 200.
Vijay, that's like your number of calls on that helpline, remember?
Yeah.
That was a very good presentation you made, really. It's kind of remained with me.
Just 2 more minutes.
Sure.
Because I can see numbers are moving up and people are still joining in. So just for them to, because of various technical reasons.
40, yeah. Make it 44 because there are 4 of us.
Okay. Okay. Everyone ready? Yep. Okay. Right. Good evening to everyone. I welcome you all for this eventful evening. Today we have 2 eminent psychiatrists and very famous psychiatrists, and both are leaders in their own respects. And we have moderator Dr. Mahesh Gowda also. I'll give you some ground rules. The thing is, I would want you to look at the bottom of the screen where it says Q&A, and I would like you to please put your questions in the Q&A section. The chat box is there for exchanging messages. If you want to say something to the panelists. So that will reach us, and we'll be able to answer there also. But I would request you to restrict questions in the Q&A section only. Okay. And unfortunately, the audience are only able to view what is happening here, and they are not able to speak here. So this is kind of such a webinar here. So with this small minor introduction, I'll hand it over to Dr. Mahesh. Over to you, Mahesh.
Thank you, Dr. Vijay. Good evening to all. Welcome you all to again the next one of the series in Telearogya. Today we have very interesting topics. We all been struggling with COVID and looking at a lot of impact on physical health and mental health. So we have Dr. Nimesh Desai today here, who's going to talk about the post-pandemic mental health care scenario. Dr. Nimesh Desai has been professor and director at IBHAS. He has held various positions at NIMHANS, AIIMS, and now has reached the pinnacle at IBHAS. He's also has held various positions at organizational capacities at IPS. He's also been the past editor of IPS, and he's known for his high spirit and for his energy levels. He liaisons very well with NGOs, does a lot of programs. And today we have him to talk on what to expect post-pandemic, and in particular looking at the mental health care scenario. Welcome to Dr. Nimesh Desai.
Thank you, sir.
Over to you, sir. I will take the next topic and the speaker subsequently.
Okay, right. Thanks, Mahesh and Vijay and Ganeshanji. It's great to be with my longtime friend, Dr. Ajit Bede. Let's roll. I'm going to, Mahesh and colleagues have asked me to talk about post-pandemic mental health care scenario, and I'm going to try and get to the slides. Can I hear my slides? Yeah. Okay, cool. Right. There we go. Let's first talk about the contextualization, the scope of this brief talk. One could talk about post-pandemic from now on, or take it as 6 months or 2 years when the pandemic is hopefully really over. One could talk about it in terms of pure psychiatry. One could talk about it in terms of mental health, psychological aspects, or also psychosocial aspects, or expand it to all social phenomena related to and after the pandemic. One could talk about merely the occurrence of mental health disorders, the epidemiology or clinical practice, or about services. One could talk about that in global context or the national context. What I've underlined there is the scope that I have kind of taken for myself for this talk. Allow me briefly, since some of the audience and participants might not be entirely aware, just to let me share where I'm coming from. Besides my psychiatry training, I've been lucky to get a public health training from Hopkins. And before and after, there's been a lot of work in disaster and conflict situations that one has been lucky to have, as listed there. And a few projects, the findings from which I'm going to keep referring to, was a long-term study that we did in Gujarat earthquake, 1 year pilot, and then 8 or 9 year follow-up there. And another long-term project in urban mental health, Delhi, Lucknow, and Chennai. I'm also drawing a lot from the experience that I had over a couple of years, nearly 2 years, in coordinating the NDMA guidelines in 2009 for what was called the psychosocial support and mental health services in disaster and conflict situations. I don't think I need to repeat that almost none of us on this earth living right now has any experience of the pandemic of the nature that we are going through. So in a sense, we are all learning about such big pandemics. One has often in last few weeks heard in scientific forums, in lay media, amongst professionals and outside, there's going to be a huge mental health epidemic after the COVID epidemic. That mental health services are going to be very inadequate. That mental hospitals and psychiatric wards are more susceptible and likely danger zones. I see it as what I see in the COVID framework also, with all respect to all the governments and all the concerned agencies, almost uniformly there is a neglect and oversight in the larger COVID framework of policy and implementation about mental health issues. And I see that really as direct and indirect stigma of persons with mental illness, the field of mental health and the mental health services. Ajit and we will remember, some of our colleagues will remember, we have always at this time related goalposts. In the late 70s and early 80s, there was the Alma Ata Declaration, all the excitement about health for all by the year 2000. We came to 1990 and the WHO World Bank report began to come through in 93 and 95. 99 was the final report, seminal, that said depression is going to be top ranking public health problem by 2020. Is this the 2020 that we were waiting for so eagerly? In humanity, or especially in mental health or public mental health? What are the possible future courses of this pandemic, as we can see today? One is going to lead to Kayamat or Pralaya or the doomsday, whatever you believe in. If not that, one is going to lead to a lot of high rates of mortality across the globe, a crescendo, so to say. Or a possibility is, as most people believe, that there could be waves of peaks and troughs, at least over the next 2 years. Fourth, soon enough, or not too soon enough, but a little later, there'll be a flattening of the curve and then it will remain there plateaued. This is obviously going to be variable across the globe. I'm recapitulating this because the psychiatric, mental health, and the psychological service needs and the service delivery is going to depend on what shape the pandemic takes. Allow me to just recap quickly what we found over a long-term project about relevant factors. We found that psychiatric disorders in urban areas in that period was only 6 to 8%. But much more importantly, the treatment gap was about 80%. And robust epidemiological methods as close as you could get to treatment gap. And the National Mental Health Survey subsequently confirmed both these findings broadly. But more importantly, we found through rigorous means in this epidemiological sample what we saw as subsyndromal mental health problems. People having significant psychological or psychosomatic symptoms, not qualifying for a disorder, not a disease or a serious problem, but disabling enough, distressing enough. And that was about 13 to 15% over and about the 6 to 8 to 10% of the mental health morbidity. And I'm going to keep coming back to that. What we also found in the Gujarat earthquake project over a 9-year period, besides many other details, is the Marfadia paper of 2017. A long-term follow-up of 8 to 9 years, 35,000 population in Bhuj and Kutch, no PTSD. Mental health morbidity not any higher than expected in the general population. Surely, initial psychological symptoms of anxiety, stress, obsessional nature, especially in Bhuj and Kutch region, almost universal. But they got better with time, sooner or later, in fact, much more sooner. The model that we evolved that's been confirmed in one or the other manner over the next 20 years is that at level 1, if you see in the first few weeks or at best 3 months, there is more than 90 or 95% of the people who will have psychological symptoms. At the second level, between 3 to 6 months, a little longer than that, about a third or a little over third of the people who will have moderate to severe psychological symptoms, psychiatric signs and symptoms, subsyndromal problems or acute stress disorders. Really only 5 to 15% of people with diagnosable mental health disorders or significant mental health morbidity. The other thing that we noted with a lot of extensive data in that project and confirmed in the tsunami work later in Tamil Nadu and Kerala, is that as is the want of the governments, states and center, whenever a disaster or a conflict or an epidemic strikes, they send experts from AIMS and NIMHANS and PGI and the state medical colleges to the field to live in the tents and look after the psychiatric and mental health needs. The fact of the matter, my friends, is that there is increased attendance at the existing mental health centers, both government and private. So what I that time called as a reverse flow of expertise. Actually, the expertise was required where you were, at least the high-end expertise. Yes, there might be some need for psychosocial support or counseling in the field, but really no high-end specialist care required there. And so the NDMA collective effort with a lot of experts across sectors, across the country over a 2-year, besides saying a lot of things, we actually did say that there should be an effort not to overdiagnose or diagnose too quickly, not to medicate unduly or too early, but also not to miss or overlook the needs of old and new cases and their families. Very delicate balance to strike, be it an individual practitioner, a small mental health center, a state, or a nation. We actually saw it as normal reactions to abnormal situations, especially in the first few weeks and months. A lot of research, including that NDMA report, actually took note of resilience and the other socio-cultural factors that I think are going to be very operative for morbidity, for course, and the outcome being much better. Very briefly, individual resilience, family support systems, socio-cultural coping mechanisms. At the cost of reductionism and quick recap, collectivism of the West versus individualism, collectivism of the East versus individualism of the West. And please flag that, because I'm going to come back to that. But in those all current situations, what is it that we can expect the trends to be in some vulnerable or spatial groups? Elderly, women, children, disabled, homeless. I think we'll have to wait for the data, besides impressions and anecdotal evidence. What often gets confused, and is already beginning to happen, I think, in scientific literature to an extent, certainly lay literature and media intercourse. The psychiatric disorder rates in recovered COVID cases or in bereaved families actually begin to be cited as evidence for high psychiatric disorder in the COVID or the post-COVID era. I think really need to be careful about that. The other unexplored area that I'm sure Ajit is going to talk eloquently about is the mental health and the psychological, psychosocial needs of healthcare workers and other frontline workers. One can reasonably expect rates to be higher here or the need to be higher here. But my caution, not to be generalized to the general population too soon. Let's come to what are the possible trends in mental health epidemiology post-COVID, whatever that post definition might be. Now, 6 months, 2 years from now. One, of course, is lots of PTSD. For some, sine qua non of any disaster, conflict, or epidemic. I think based on evidence, very unlikely. Increase in prevalence and incidence of severe mental disorders. Again, very unlikely. Increase in prevalence and incidence of common mental disorders, the entire spectrum, possibly, as is well known in a lot of quarters. Urban-rural differences, gender differences, others. Increase in acute stress disorder, yes, for the short term. Anxiety spectrum disorders, specifically OCD, yes, it could be, and lot of evidence and experience seems to suggest that it will. But then there is also the whole issue of what will be the new normal. Would generally normative obsessive behavior redefine some obsessional phenomena? What I believe is already in the community and is likely to happen much more definitively is the increase, if at all, in subsyndromal short-term mental health problems. I'm sure it's evident by now that I am more in favor of the apparent mental health epidemic rather than the real mental health epidemic. And so this apparent or perceived mental health epidemic or anticipated mental health epidemic, in my view, what are the contributors that lead us to this premature conclusion or this conclusion? One, there is certainly epidemic-related recurrence and relapse of on-treatment cases. Very well established, incontrovertible. Cases who are in treatment gap get identified, get distressed, get brought to treatment or come forth. Persons with acute stress disorder or transient self-limiting anxiety spectrum disorders or subsyndromal mental health problems coming to treatment services or found in the epidemiological studies or community outreach services. To me, these are the factors that lead to that mistaken belief about a huge mental health epidemic looming over us. Switch gears, the last part. What the role of mental health professionals or mental health agencies in such situations? I mean, based on all the previous experience that many of us have had and agencies have had. First, strengthen the hospital-based work. Prepare adequately for continuation of mental health services rather than jumping to the field. Manage recurrence and relapse of previously treated cases of psychosis and epilepsy and stuff. CMD, stress-related disorders, yes, we need to be prepared for it. If at all some of us are inclined to get to community-based work, work as health workers or relief workers with normalcy paradigm rather than psychiatry or mental health paradigm. Integrate your work with the relief and rehab work. Provide support and listening for those who need. Encourage very promotive activities, positive mental health activities, and I wish we had time to discuss that towards the end. avoid undue diagnosis, avoid overuse of tranquilizers, and follow up of the defined cases, as we did in Gujarat. Look at it differently. Besides one's own direct clinical work, mental health professionals, psychiatrists, clinical psychologists, others might do advocacy, increase awareness, surely. But we believe not psychiatric or mental health model, the psychological aspects of advocacy. Training of community level workers, physicians, others. Really important, strengthen your backup specialist services wherever you are. And if possible, carry out action research or operational research. And so what would my list be for mental health service needs for a society, for a state, for a nation? The to-do list. 1, sustain and strengthen available mental health services. 2, try and make sure the mental health services become more and more professional and quality assured. Thirdly, reach out more to the community for appropriate needs. More technology assisted services. A huge question about counseling services, a debate in itself today or sometime later. And of course, as Ajit will tell us, mental health service needs of health and other frontline workers. That'd be my to-do list. Towards the end. So what are the opportunities that we have really? Advocacy, yes, very, very big opportunity, but not drum beating, with all respect. Appropriate and commensurate to data kind of advocacy. Strengthening of mental health systems, yes, not irrational undue expansion. Need-based mental health responsive systems, not knee-jerk reactions. We also have opportunities for broadening the concept of mental health beyond psychiatry or psychiatrists or clinics. One more opportunity for multidisciplinary mental health team approach. Intersectoral collaboration beyond mental health teams or even health sector. Recognition of the psychosocial impact of the situation. Epidemic, lockdown, the after effects. And so, to summarize, we have a chance, besides our own work being stronger, advocacy and resource allocation for mental health. 1, based on the principle of justice, as many of us in different states are doing under the Supreme Court directive for the migrant labor groups. And we have had fascinating experiences there. To tell you in 2 sentences, the rate of psychiatric or mental health morbidity is no higher than general population. Psychological distress, yes, reality-based. Increase funds as an ethical obligation. Even more importantly, as a legal imperative because of the MHA provision of mental health care as a right. So these are the things perhaps we need to do advocacy and more work for. In the end, I'll just remind myself and friends like Ajit and Mahesh and others and many of the listeners that there are negative utopias like 1984. And one negative utopia that actually spoke about very close to now, 13 years. Published in 1985 by this famous author of Thornbirds, Colin McCullough, who wrote a small book, relatively less known, A Creed for the Third Millennium. Set in 2033, the protagonist being a clinical psychologist and the entire human race being in a state of what she called as millennial neurosis. Are we on the way up to that? I hope not. And I believe not. We shall overcome, not only we shall overcome, but stabilize too. Besides many other factors globally and behavioral economics, I dare say the collectivism of the East will help us fare much better than the individualism of the West. Thank you so much.
Thank you, Dr. Nimesh. That was wonderful hearing from you. We would take the questions in the end.
Yes.
And now I'll have the pleasure of introducing the second speaker. I would like to welcome Dr. Ajit Bide, also popularly known as Shashi Tharoor of the Indian Psychiatric Society. Welcome to you, sir.
Thank you. Happy to be here, Mahesh.
Dr. Ajit has been the past president of Indian Psychiatric Society. He serves as professor and HOD at the Department of Psychiatry, St. Martha's Hospital. He's also the teaching faculty for Spandana Nursing Home. He is popularly known for his work in recent times on LGBT task force. And Dr. Ajit has special interest in child and adolescent psychiatry. Today, he's going to talk on his passions and interests, that is on defending the defenders, COVID-19 and mental health needs of the health professional. Over to you, sir.
Thanks, Mahesh. Thanks very much. It's an honor to be here and to follow up with Nimesh is a challenging task. Nimesh, I really enjoyed your presentation. It was, in its own way, provocative, as we discussed the other day when there are the doomsday prophets that we mentioned. I am sincerely hoping that they are here and willing to participate in the discussion that will ensue. Well, let's get on with my brief today is about the mental health needs of health professionals. Setting the scene, I'm quoting somebody who had a background in surgery, and then she chose to have a background in mental health and also specialized as a psychiatrist, went back to practicing surgery after all, and she witnessed some tragic incidents in the, can't even call it really the aftermath, in the course of this COVID pandemic that we have. And Wendy Bean says, healthcare workers are well trained to manage the intensity of a medical crisis, but few are equally comfortable managing its mental health aftermath in themselves or in others. Even before the pandemic emerged, model injury, and this is a very interesting term, about 2.5 decades old, we'll talk about it if we have the time, and burnout, which we are all familiar with, were rampant among clinicians. In fact, there are studies that have been conducted mainly in the developed countries, a few in the developing countries as well, which rate burnout phenomena among clinicians as being between 10 to 80%. That's how common it is. And we're not speaking necessarily about the pandemic, because it says over here, even before the pandemic, burnout was rampant among clinicians. Coping with COVID-19 has magnified many of these challenges and added new ones with the reality of resource constraints. And nowhere do we encounter this more than in developing countries. We're living in tough times, and finish. I need a little help. Let me get this in. Sorry, just a minute. So we're living in tough times. It is a duty above all else to be available for helping handle and also actually handling the morbidity of the COVID epidemic. In many countries, it might not surprise you to hear this, but even psychiatrists have been called on duty because there is such a shortage of doctors. This has happened particularly in the Asian and now in the African countries. There are 4 Ds. 3 of these are purely psychological. The last can't be psychological, but I've included over here. Dread, that is anxiety, despondency, largely depression, distress, and even death are attendants of the scourge which is upon us. And we have to be part of handling these attendants and sequelae of the disease that we are facing. In the course of handling these, we must never lose sight of the fact that handling crisis and critical clinical situations takes its toll on those involved in the caregiving, that is us, healthcare workers, whether you're a doctor, a nurse, a paramedic, even people who attend to labs, and there are lots of people doing lab duties late into the nights with this pandemic upon us, and also other forms of other therapists. Frontline medical workers are at a risk. We know that they are at a risk for physical health problems, but from COVID-19, but also psychological ones, and that is one that sometimes is paid scant attention. Data from previous pandemics, particularly after quarantine, and this happens most in the case of the Zika virus epidemic that took place that was feared to become a pandemic, unfortunately did not, and Ebola, suggest that healthcare workers might develop symptoms of post-traumatic stress disorder, depression, and very important, and something we haven't mentioned yet, substance abuse. Because we need to drown our sorrows, don't we? It's a Saturday evening, don't forget that. Preliminary data from China and Italy during the COVID-19 pandemic offers further evidence that healthcare workers in China, this was the first report that came out, I think at the beginning of April, reported depression in 50.3% of cases, anxiety in 44.6%, and insomnia in 34.0%. Now, you will notice that these are not, there are overlaps between these 3 syndromes, and that's why you get a total of much more than 100.
Type in questions. Stay anonymous if you don't want to put your name.
Something? Shall I carry on, Mahesh?
Yeah. Yes, sir. Sorry, sir. Sorry. Please carry on, sir.
A word about suicide among healthcare workers. And the first reported suicide actually what happened in Italy, but there is suspicion that there were perhaps cases of attempted suicide even in China. The ones that have been well documented are the cases of a clinician, a doctor, an emergency care doctor herself in the USA, as well as of an intensive care nurse also in the USA. Now, what happens when you're attending on potentially fatal cases, and this COVID certainly is a potentially lethal illness, is that there is a burden of guilt. Almost invariably, healthcare workers who are in the intensive care scenario, critical care scenario, they have this phenomenon of, though they don't admit it as such, a feeling that they are there only necessarily going to save lives, that their fatal outcome is a reflection on their competence necessarily. And so one healthcare worker writes, even if it was an inevitability, even if there was nothing they, that is the healthcare professionals could have done more, death is seen as a personal failure, that I have failed my patient. And that is an awful, awful feeling for anyone to have to go through. This phenomenon of this being laden with guilt is much more common among nurses, especially middle-level nurses, not the very junior ones, not the very senior ones, those who are really getting into a groove of critical care. It's much more common among them. It happens among junior staff very commonly because they're there as heroes and they find that they can't always function as in the heroic role that they have portrayed for themselves. And it also occurs among highly conscientious, I might add, workaholic doctors, because they believe that they are there to save lives, and if they fail to save a life, it's a personal failure. When these are the people much more likely to have severe depression and to perhaps engage in acts of self-harm and even end up as unfortunate suicides. Now, one of the key references for my study today, and I have borrowed a lot from the net because this is not a field I'm extremely familiar with, I'm very concerned about it. Hisley and colleagues, and when I give you the key references, you will find the reference, very recent reference from 2020, report a rapid review and meta-analysis of qualitative, cohort, and cross-sectional studies, which examine the psychological reactions of healthcare staff working in any clinical setting during emergency virus outbreaks. These are varied outbreaks, all of them very severe. So you have the SARS phenomenon, you had the Middle East respiratory syndrome, which was perhaps a variation of SARS. Then you had the H1N1 or the porcine influenza, H7N9 influenza, the Ebola virus, which I mentioned in passing a little while ago, and of course our good old COVID, old already. Using several databases such as the Cochrane Central Register and Control Trials, the PubMed data, Embase data, PsycInfo data, Med Treatment for data, these authors, Hisley and colleagues, they compiled altogether 282 potentially relevant full text papers. And they had very strict inclusion criteria. We haven't the time to go into all of those. But ultimately, 59 papers met the inclusion criteria. That's about 1/5 of the total number of papers that they actually had on hand. These studies looked at risk factors for stress and psychological distress and successful measures to manage them. Let us first look at the stress and psychological distress factors in some detail. I've largely borrowed from Hisley and colleagues' work, but I've also added my own insights into this and the data from other disaster-related studies that we do have, including some from India that Nimesh himself was involved in. Aggravating factors for mental morbidity, we call it MM for short for now. Now, when you have a pre-existing MM, and that's a no-brainer over here, even if apparently fully recovered or remitted, especially in the case of psychosis, if you have a pre-existing MM, then the chances of that getting aggravated are there. Also, if there is a family history, and if there is genetic relationship with a person who has a mental illness in the family, the risk is much more. But mind you, it doesn't have to be genetic. It can also be an environmental factor where you have a family member not genetically related, most commonly the spouse, that also increases the risk of mental morbidity. Then, of course, you have psychosocial stressors, particularly when there is a lack of adequate social support. And we have, you'd be surprised how many nurses there are without a good social support system in their lives. Other stresses and the warriors. We look at one set of people over here. Facing highly distressed patients is a huge stress for many, many people. Over a period of time, people get seasoned and they know how to deal with that. But also remember, when you have a disease like COVID, many of these patients are actually moribund. They are nearing death, and we have to rescue them, pull them back from that line. Seeing death at close quarters imposes a lot of stress, and sometimes, in particular wards that have been designated for this particular illness, you see this death repeatedly, and that really tells on the person. We mentioned that brings guilt to many healthcare workers, and naturally there's a potential for different kinds of psychological breakdown, apart from suicide, which we've already talked about. Then, apart from the patients themselves, there are the caregivers. Patients' anxious relatives constantly asking, hey doctor, where are we now? Is there any hope? Shall I do this? Can you please reach these ashes that I've brought from these angara which I've brought from Shirdi? Can you do this for? And all this tells of the doctor taking charge of that patient, doctors and nurses and all the healthcare workers involved directly in the critical care. We have other phenomena which are the bane of our professional community: overwork. I'm tired of stating this, but it's never enough to say that in our country, our junior doctors, particularly those from senior residents down to the PG students to the SHOs, they do not even get 24 hours off in a week just to be by themselves, attend to other necessary duties, other necessary activities of theirs, even to recharge their batteries. So inadequate scope for recharge does increase the stress for all healthcare workers. And of course, we've been seeing, especially in the UK, but the world over, there is a lack of personal protection equipment. And these shortages, you're going over there, you say, okay, I'm a hero, I'm going to fight this, but the basic personal protection equipment is not given to you. Or you asked to recycle it without adequate sanitization of that equipment. That is a huge, huge stress. In other words, you're thrown into a battlefield without adequate armamentarium for yourself. Then there is a paradox of the family proximity. People who have been in the situation want to get back home. The people at home want him to come, but the educated people at home say, hello, he's coming from a critical care background. Is he going to bring infection into the house? And you're worried yourself that am I carrying an infection into the house? So there is a paradox, so to say, between the need for this proximity and again the risk of the proximity. This was very beautifully brought out in a recent documentary that called itself professed to be about the lockdown, but was really about individual cases. It was aired on the National Geographic. I urge you to see it. It's available on YouTube. Please see this. But a young female doctor in a small town in Maharashtra, not so small town, it's a small city, Sangli. And this girl is from Kerala, and she is facing this situation of being in a critical care ward, looking after COVID patients. And the first patient she has to take us has died by the time she's gone there to take this one. And it tells on her mental health. So what is the relevance of this particular example in this particular case is that her husband, we are not told whether he's a doctor or not, he arrives on the scene, and that eases the burden greatly for her. At the same time, she's very, very worried in this young couple that she might pass on the infection to her beloved. Adverse socioeconomic circumstances, lower household incomes, pooling all the incomes, usually the husband and the wife, sometimes even grown-up children. If the gross income of the family is low, having children at home, because you're always worried about children's health, above all else, in most families at least, having an infected family member, and then there are quarantine-related family stresses. It is well known for decades now that when you have quarantine situations, the incidence of phenomena like domestic violence does go up. And when you have these kind of circumstances, adverse socioeconomic, children at home, an infected family member, and quarantine-related family stresses, all these lead to a greater chance of mental morbidity. Getting back to the theme of the personal protection equipment, wherever you see quotation marks, I'm actually quoting from a paper that I have gone through and liked. Concern about inadequate PPE during COVID-19 pandemic have focused on the risk of infection. Adverse effects that lack of PPE could have on mental health are very many. Such institutional betrayal, that's a very graphic term that has been used, when trusted and powerful institutions act in ways that can harm those dependent on them for safety and well-being. All this compounds the trauma for the healthcare giver. Now, healthcare professionals will find some relief in the fact that a lot of garment factories, and even in Bangalore and Tirupur, which are well known for garment industries, are actually busying their production lines with personal protection equipment. What's happening in the West? Similar things are happening in the West, but not nearly enough. We know that the USA has crossed 1 lakh in the mortality, but what is very telling is that the lack of personal protection equipment is believed to have contributed at a minimum to about 10% of the mortality, and that's not a small figure. To mitigate this, organizations should support staff voices and efforts to obtain PPE whenever and however possible. What do we do about all this? We've spoken so much about the morbidity. There's the old adage, physician, heal thyself. Are we ready to heal ourselves? What can we do about the mental health hazards for professionals spearheading this defense against the scourge? Again, quoting from another paper, these are defense mechanisms that operate very, very commonly among us. Denial, minimizing, and compartmentalizing are essential strategies for coping with a crisis. We always speak of denial as something terrible, but at one stage it's absolutely necessary. These are psychological tools we reach for over and over to get through harrowing situations. Healthcare workers learn this through experience and by watching others. When you have an admirable senior, usually your senior resident, when you're a junior PG student, that's the best example for you. We pick it up subconsciously and also consciously emulate such tough behavior. We learn how not to pass out in the trauma bay, as Dr. writes. We learn to flip into the rational mode when a patient is hemorrhaging or in cardiac arrest. We're looking not only at the COVID situation, but generally in emergencies. Attending to the details of survival, the vital signs, lab results, imaging studies, unfortunately relying much more on lab data and radiological data rather than the actual bedside studying of the patient. We learn that if we grieve for the 17-year-old gunshot victim, fortunately not a common phenomenon in our country, while I don't no marks for guessing which country we are talking about or which country this quote is from. We learn that if we grieve for the 17-year-old gunshot victim while we are doing chest compression, we will buckle and the patient may die. So we shut down feelings. This is something doctors learn, and this is something which stands them in good stead, but beyond the point, it is going to take a toll. So we shut down feeling and just keep doing. What few healthcare workers learn how to do is manage the abstractness of emotional recovery when there is nothing to act on, no numbers to attend to, no easily measured markers of improvement. So what can we do? It is good necessarily to have a mental health professional. We know we seriously are outnumbered. We have too few mental health professionals in this country. I have a controversial opinion about this. I think we need many more psychologists, and of course we need a lot of psychiatrists, but I think good psychologists can do a good job being on the critical care team. They can function as ombudsmen, the sort of liaison people who are available all the time, perhaps by turns. It doesn't have to be the same person available all the time. Also, there needs to be a consistency, and there needs to be a proper handing over of duties among the mental health professionals. Also, of course, competence is always an issue. So on the critical care team, we would have somebody who has at least 5 years experience of liaising with physicians and critical care workers. Also, as already mentioned, this bears repetition. You'll forgive me for repeating this over and over again. Adequate respite from high tension work. People who are in critical care need time off enough to recharge their system so that they can come back and do a good job. They are continuously taxed over and over again. That leads to them getting fagged out and the clinical phenomenon of burnout. Also, in the clinical scene, there needs to be clear communication. There should be good role definitions, but at the same time, we cannot go only by clearly cut role definitions. There should be a hierarchy, but the hierarchy should be a little malleable, and there should be a sanction for overlap between duties. And for this, you need seniors who are adequately competent in different fields and can take junior person. Okay, now you let go of the ventilator, you attend to this particular thing, with someone else, of course, looking after the ventilator. It bears repetition again that we need adequate personal protection equipment. And there has to be a scope for the healthcare workers with this ombudsman mental health professional for them to have a debriefing. They have to be able to spend time with the mental health professional, and mental health care always calls for time. Time must always be available to this healthcare worker. Time must also be available to that ombudsman mental health professional to talk about what they are going through. And many people have told me that they feel so much relieved after they have talked to a mental health care professional. Also, there is this notion, common among the general populace, no doubt, but also within our professional broadly. Hey, you needed to see the shrink? You must be a weakling. You need to be tough. How can you come to critical care if you're going to be so weak? So there is this notion of weakness, and there is the stigma of seeing a mental care professional, which we are battling on various fronts, but also in the context of this pandemic, we have to deal with this. Very important for all this to be properly administered, we need dynamic leadership. We need competent people at the top who have good management skills, who have good person skills. Without that, there is precious little we're really going to be able to deliver. Psychosocial and workplace measures can improve employees' working lives and suggest that these in turn can improve mental well-being, even though they are not explicitly mental health support services. Interventions to ease caregiver or childcare burden or lessen financial stresses such as hazard pay might mitigate negative mental health outcomes. Self-care is also critical given the benefits of diet, exercise, and sleep, says this quotation. I would add a little bit of recreation, a little bit of indulging in hobbies and pastimes. Even browsing the multi-channel TVs is something that most people need a little in their lives. Without that, they are going to be absolutely drained out of all their psychological reserves and resources. There is scope for generous state patronage for high-risk professionals. I'm not here to make any kind of political statement, but I was very impressed when, right at the end of March, the West Bengal government announced special insurance scheme for people dealing with COVID. And I think that was a phenomenal step taken forward. I believe it has been emulated by many other governments as well. I'm not sure about the central government. But what we're talking about is compensation assurance for potential risks of long-term medical and mental sequelae. That, of course, is part of New Asia's province, and we'll discuss that at some length, hopefully, during the discussion. And also remembering that we need this compensation assurance because we're dealing with a potentially lethal outcome. To conclude, I would say there is power in positivity. We can get very cynical about situations like this. We can get very defeatist in such situations. But as C.S. Lewis, the British author, had this to say, you can't go back and change the beginning, but you can start where you are and you can change the ending. And hopefully that is going to be a happy ending. These are the key references. I'm going to leave this with Ganeshan and Mahesh to share with all of you, because I think these are seminal resources for us to understand what we've been talking about, the mental health care need of healthcare professionals, particularly the first task. The second is also worth watching. There are interesting people over there. Thanks, Dr. Mahesh Gowda and Dr. Vijay Harbishettar. Sorry, Vijay, I didn't include your name over here. I ought to have done. Thanks also to Microlabs, especially Mr. Ganeshan, and who are our hosts and sponsors. Thanks to Dr. Nitin Yashas, medical oncologist in training, my student by proxy, so to say, and also somebody I'm learning a lot from, medical oncologist in training at the Manipal hospitals. And thank you all for being here and for listening. It serves well to have an optimistic outlook. So Charlie Brown says, someday we will all die, Snoopy. Snoopy replies, true. For all other days, we will not. We will not. We can do it. To quote Barack Obama, was it? We can do it. We shall do it. Thank you very much for your patient listening.
Thank you, Dr. Ajit, for your wonderful presentation. There are a lot of questions in the Q&A section, and there's a lot of discussions on the chat, which actually generates a lot of discussions too. So I thought the first question to Dr. Nimesh should be, pandemic being an extremely stressful event leading to possible PTSD in the vulnerable population is a possibility. How do you respond to this? Dr. Nimesh, are you online?
Yeah. Mahesh, thanks. I have answered almost all questions on the Q&A and chat, but let's discuss it here briefly. As I've said, PTSD, very unlikely. Acute stress disorder, as somebody else asked, even acute stress disorder of psychotic proportions. So as some other clinical colleague was saying, ATPD, as she said, possible, but not really long-term PTSD.
Okay, there's also one question which is actually talking about PTSD. One minute, so I'll just pull it out.
I did that. Mahesh, before anything else, can I say something?
Yes, sir, please, sir.
See, our friend Nirmala Srinivasan has already asked twice in the text, why did you introduce Ajit Bide as Shashi Tharoor? I think you must clarify.
Yes, I'll do that in the last.
Linguistic aspects.
Yes, sir.
I suppose.
Yes, sir. Yes, sir.
Because Nirmala has typed that in twice. Yeah.
Sure, I will do that, sir.
Only for the vocabulary and the language aspects.
Okay, sir. There's also one question that to Dr. Desai again.
Sir.
You mentioned about surge in patients with anxiety and stress-related disorders. Do you think post-COVID pandemic scenario will be different from other post-disaster scenarios with respect to the pattern of clinical presentation?
Yeah, my own faculty colleague, my dear Om Prakash, asked that and I answered that, but you share with everyone. Yes, that's a possibility, especially for OC symptoms or OC disorder or even for their anxiety. I guess we'll have to wait for at least clinical descriptive studies to see if there is really a change in phenomenology or presentations.
Okay, so there's also one other issue about ATPD.
Yeah, I answered that. Remember, one of our colleagues was saying that she has seen a few cases in young people who are not able to appear for exams with psychotic symptoms. My sense is that we'll have to see if it is psychotic proportion of an acute stress disorder, which is a recurrence or relapse of an earlier undiagnosed disorder. You know, till now, as I said to her, I think Dr. Vasundhara it was. Till now, we have had no evidence from any research for ATPD related to such stress. Major.
Okay, sir. There's also one question which I think both of you can take. How to actually prevent suicide in corona positive patients?
Ajit, you?
Right.
I'll come, please.
Once again, Ramesh.
How do you actually prevent suicide in corona positive patients?
Corona positive patients, not necessarily mental health care professionals, right?
Correct, sir.
I think it's not very different from anybody in acute stress who has suicidal urge. We need to ensure as far as possible that they have a good social support system that's going to take care of them. In the acute stage, of course, we have to be available to them. And if somebody with, I had, the first case I saw was actually in February. I was just mentioning it to some other colleagues earlier today. This young man from Maharashtra who had a long stint in Canada had come back to India, and he sized up the situation very soon, and he was absolutely desperate. He's a techie in Bangalore, and he said it's the doomsday, no point in living anymore, and so forth. I think the debriefing that needs to take place is not very different from those faced with acute stress of any other nature. It could be bereavement, it could be severe financial loss, it could be any other potentially lethal diagnosis like AIDS or cancer or severe tuberculosis. We have to be around to tell them that life is going to be worthwhile. And this is a challenging task in the face of COVID and in the face of high levels of mortality. Relatively speaking, we know that vast majority do improve. And that's the aspect of the disease that we need to highlight. And that is very, very important, and is best done by a good skilled clinician with figures at his fingertips to tell them, this is what you need to do to be among the survivors, and you don't have to give up.
Dr. Nimesh, would you like to add something for that?
Yes, what I said in the text is that I guess all the standard protocol for suicide prevention in the community, especially in hospital settings, will apply. I would just be a lot more vigilant than I would even generally be, because the distress related to COVID positive state can be so unpredictable. And so I guess the same protocols with a little more vigilance if you can.
Okay, sir. There's also one scenario for the benefit of all the people who are listening. I wanted Dr. Nimesh to answer this again. I know you answered it in the text format.
Sure, sure.
Adolescents are not able to take exams during lockdown, and board exams are also on hold. The results are also on hold for a lot of people. Few of such people have come up with ATPD sort of presentation. So this is an observation which they wanted to comment.
Yeah, one of our clinical colleagues, I think, made this, and I was asking her on the chat whether it is a clinical or a societal or an anecdotal experience. And she said a few cases in the clinic. My sense was to her and to everyone here to consider is that, like I said, this is either acute stress disorder, which is being misperceived as psychotic, or even with psychotic symptoms. Really, ATPD in young people related to stress, I don't buy that too much, frankly, unless there is really good evidence that we can have.
Okay, there's a question to both the panelists. What is actually causing more mental health problems? Is it the pandemic or people getting affected by lockdown? Because of minor problems, we are getting more calls related to frustration and irritability increasing out of lockdown itself.
I just wrote to Aninda, neither.
I was going to say both.
Now, firstly, there is no increased mental health morbidity, man. So really, I think we need to be very cautious about saying there is mental health pandemic following epidemic. You know, as you have said repeatedly. Acute stress disorder, anxiety symptoms, stress-related subsyndromal symptoms, yes. And that, like Ajit is saying, is for both the fear of the epidemic as well as the lockdown effect. That I agree, Ajit, sure.
Okay, there's also a question to Dr. Nimesh about advocacy, awareness for psychological and not psychiatric issues or mental health.
Yeah, I wrote to Nirmala that let's go beyond psychiatric disorders, persons with mental illness only for our advocacy, and talk about psychological aspects of all families concerned with PMIs, psychological aspects of physical health, psychological aspects of day-to-day stress, psychological aspects of disasters and epidemics like this, you know. The advocacy, I believe, is likely to succeed much more if we can carry the psychological or psychosocial component with us rather than talking purely about psychiatry.
Okay. There's also a question wanting to know about is there any systematic...
Ajit wanted to say something. Ajit.
Yes, sir.
There's a
Yes,
question
sir.
from Dr. Charles Pinto of Mumbai. Did you take that? Right. The very first question that's here on my screen is from Dr. Charles Pinto. Dr. Ajit, would you consider mental health professionals as one of the team of the frontline doctors for the pandemic? I think it's very, very important, and that's what I mentioned, that there must be a mental health component in the critical care team generally, but especially in the context of COVID, where mental morbidity is something of concern. Though I know that Mahesh has been saying that it's not an epidemic, still it's good to have mental health component over there. So you could have a psychologist and a psychiatrist, or two psychologists and a psychiatrist supervising them. Some kind of ombudsman available over there is very, very necessary. Also, do you visualize high mental health morbidity in frontline workers? The China data is the best that has come to us. Subsequently, there's data from the US as well as from Italy. And their depression and anxiety were the most marked morbidity, mental morbidity diagnosis that we had. And some people did not have either of these, but only pure insomnia. That was also there. Insomnia as a part of anxiety, insomnia as a part of depression was necessarily there. And we know that critical care people are prone to biological dysrhythmias, whether it's their appetite, whether it's their eliminatory functions, most importantly for their sleep and their they really go for a toss. And this needs to be addressed very, very carefully. So yes, I would agree with you that I visualize high mental health morbidity in frontline workers. We've already talked also about suicide. That risk is there. But these are people who probably have a high conscience, a poor social ability to mix. So they are more isolated. They have a tendency for depression, and these are the people who are at the greatest risk.
Can I also add that I completely agree with Ajit. In fact, I want to say that what Ajit is suggesting would be a much better model than what some of us have done. The National IMA launched a telecounseling helpline for health workers. I think the uptake has been very poor. We from Delhi SMH and IBAS with Delhi Medical Council, Delhi Medical Association as partners, to get doctors and healthcare workers to participate, actually launched a helpline for frontline workers about a month ago, Samarthan. 8 a.m. to 8 p.m., confidentiality ensured, whatever else. Virtually no takers. So there is that hesitation, there is a stigma. If you sit back and say you will reach out to us for counseling, that's where I'm saying that what Aditi is suggesting would be a much better model. And some general hospitals, as we know, do have that. On COVID wards, a psychology or a psychiatric colleague, you know. And so rather than, in fact, I'm almost reviewing my Samarthan outline, helpline. So what Aditi is suggesting might be a lot better idea.
And we have evidence with Scandinavian countries and Germany. This is where mental health care is the best so far in the context of COVID. I think they've done a very good job of having mental health professionals on the teams.
Right, sir. There's also an issue about the migrant population. Has there been any systematic studies or data collection planned for migrant populations?
Yes, I again typed the answer there. See, we have had data some weeks ago, and we're continuing with that, on about 18,000 persons studied in shelter homes by now by our teams. And the rate of psychiatric disorder as well as non-psychiatric mental health morbidity, psychological symptoms, is about the same as general population. In fact, we were very surprised with all the hallabu and all that's been going on. You know, the government as well as the Supreme Court expected there's going to be a lot more. It isn't. Indeed, except for the reality-based Maslow's hierarchy-related anxieties, which we completely empathize with and see as normal, there's very little other issue. And as, more importantly, now in last 2 weeks, at least in Delhi, as people are being sent back from the shelter homes to their choice of state or to their work in Delhi itself, it's getting better even than it was.
Dr. Vijay, I would need your help to pull out some questions from the chat section also. I'm looking at only the Q&A.
Oh, I have that, not a problem. I have that.
Sir, there's also one other scenario explained by Dr. Naresh. He's
Yeah,
saying
I saw that.
COVID is not going anywhere. How do you treat a COVID positive case on psychiatric ward if the patient is suffering from schizophrenia, paranoid type, bipolar mania, or hypomanic episode, or a severe depressive episode while performing ECT? So how do you actually manage?
Yeah, very relevant clinical question. My colleague Om Prakash, who actually is in charge of the ECT facility here, and our anesthesiology colleague, and we have all derived only a week ago now, laid down SOP. I don't know how many of us will agree here or outside. We have said, since ECT being the procedure it is with such possibility of transmission, COVID negative state will be essential. One, even if it gets delayed by a couple of days. Two, sanitization of the entire facility after each ECT procedure. So the two major things that we have kind of said to ourselves and we are going to try and follow is COVID negative state and sanitization of the entire facility after each ECT.
There's also one of the, anything else, sir? Dr. Ajit, you want to add something?
Vasudha Rao has a question.
Yes.
Could you please elaborate on how to offer help to medical professionals in a way that is explicitly mental health, that is not explicitly mental health services? This is a question we battle all the time with, grapple all the time with, and frankly, trying to do this will be much obliged if we get some tips. I was not one of those who was very enthused when the Family Planning Ministry decided to call itself the Family Welfare Ministry. I think you should call a spade a spade. So if you don't want to call yourself mental health professionals, start with saying that anybody could have a psychological stress situation, and we are stress management experts. I mean, if you want to use euphemisms, please use them. I'm not quite Shashi Thakur, maybe Shashi will have better answers for what terminology you'd use, but you are basically a mental health professional. And reach out to your colleagues and say that, listen, if you need support, I'm here. If your junior colleagues especially, and they're very vulnerable, need support, we're here. I don't think there is any way of gainsaying that we are basically catering to psychological needs. If you don't want to call them mental health needs, the word mental obviously has too many negative connotations. And so we get around to saying psychological. But there's no circumventing the fact that we have to call a spade a club in the form is a different form, a diamond in a different form and a different color. You don't call a spade a spade.
There's also one question by Dr. Shubhangi: how to work on preparedness of frontline healthcare workers to face critical situation because of everybody is caught into it so abruptly.
Sorry?
How to work on preparedness of frontline healthcare workers to face critical situation because everybody is caught into it so abruptly.
Right. I think there is a certain degree of preparation as medical professionals we need to do when we are venturing into a field of critical care. And I think we have to be, especially as younger people, have to be aware of the fact that we are facing potentially lethal situations, that we are going to commit ourselves to doing our best. We're going to commit ourselves to acknowledging whatever minor lapses there might be. Hopefully there are no major lapses. I know they do occur. And we are going to liaise with our colleagues to find out if we can't come up with a ready-made solution. Maybe they can, collective thinking can go a long way in resolving difficult impasses that we are bound to encounter in a critical care situation. So I think preparedness will start early. It's got parallels with soldiers going out to war. And I think that analogy has been weather-beaten, but it's still rich with meaning. That we have to be mentally geared to say that, hello, this person might lose his life. I'm going to be there with my team to try and rescue this person from what could be a lethal outcome. I think that is general, not so specific for COVID alone. Right now, of course, we're facing COVID. That's for all critical care situations. All ICU doctors, there is so much data on the kind of burnout, the kind of anxiety, the kind of stresses that people working in ICUs go through. And they have to be prepared from a young age. And each time they go in, they have to be reminded that if there is any problem, there is somebody or someone, some team to fall back on, including, as Charlie asked, a mental health professional on the team.
Can I just add that? Can I just add, sorry, that in one of our webinars, we had two of our colleagues, Shruti Srivastava from UCMS and Darpan Kaur from the Mahatma Gandhi Medical College in Navi Mumbai. I'm sure there are others, but these two colleagues actually shared their experience of systematic module for preparing the doctors and nurses and other healthcare staff being posted to COVID wards. So maybe we can find out from across the country if there are modules that people have developed, besides what Ajit said.
There is one more question somebody's asked. I just mentioned it. My hospital has arranged online mindfulness for the providers twice a day during this stressful time in Seattle area, Washington State. So what's your comment on that?
I think it's a good idea, but I think you don't have to go to Washington State at all. Washington State, incidentally, is the place where COVID first struck in the US. So now there is a suspicion that there was a Chinese hospital in the Bay Area which first encountered COVID, but they tried to suppress the data because they were Chinese.
The point is about mindfulness. Mindfulness.
Yeah, mindfulness is available. Yeah, man. Vipassana is so close to mindfulness.
Yeah,
Vipassana
absolutely. Absolutely.
So many trained people in mindfulness, but they don't have foreign surnames, so they may not be so appealing.
Yeah, I had a question. Does this psychiatric morbidity
Just a minute. Let me quote somebody. Rajendra Barve in Bombay, doing big time work in mindfulness. I think we should have particular names. Dr. Chokhani in Mumbai.
I have done Vipassana 10 days.
Harbi Shettar in Bangalore.
Yeah, absolutely. Yeah. My question is, I mean, does this leadership quality of the team lead leading the healthcare warriors in the frontline healthcare warriors matter, and how does it matter?
It matters because the general management is a lot depends on leadership. In mental health or any other field, but we have of relevance to us here is mental health. I think leadership decides what the quality of care that is going to be given. You need a leader who, it's like when my father taught me driving, he told me, holding onto the steering wheel is like how you're going to handle your wife in the future. Hold it too tight, you're not going to go very far. Hold it too loose, it's going to go berserk. So I think a good leader is somebody who knows how to man the wheel properly. And you hold on to the wheel just with the right amount of control, giving sufficient freedom, because these are people who have had their own clinical training, you are now fine-tuning it. A good leader would also have some person skills to recognize when somebody needs a break, when somebody is burning out because of overwork, when somebody is having great problems. And these are situations we encounter in clinical practice all the time because we live in a high-tension profession. We have to. There is no getting away from it. Life and death situations all the time, cliched as it may sound. So we need to have good leaders who recognize these things, who can delegate responsibilities properly, who can pick up skills, who can pick up deficiencies and handle the deficiencies initially in a non-threatening way, eventually giving a warning, and then taking stern action. There have to be levels of disciplining within the field as well, and a good leader does that well.
Would you believe, and some of you know about the first two experiences that we have had in May. One homeless, destitute, mentally ill person detected positive on 2nd May. One more staff nurse 2 weeks ago. And last night, one destitute homeless person in neurology ICU in the hospital for last 3 weeks. But in continuation of what Ajit is saying, lo and behold, this noon, when we put together all the ward attendants, nurses, and doctors who had looked after that person who passed away this morning about neurological illness, and offered quarantine, almost all of them said, no, sir, we don't need it. We'll continue to work. So besides everything else, the opposite of what Ajit referred to so well as institutional betrayal, if you can build that idea of service with flexibility to individual needs.
With one caveat, Nivesh, quarantine becomes necessary at certain times. And then these very valiant people who are extending themselves must be told that for this reason, you need to be in quarantine anyway.
You see, Ajit, my dilemma has been that on 2nd May, we'll recall, as I shared on Facebook, we quarantined 75 persons. Apparently, my colleague said that, sir, the policy has changed.
Okay.
Now, for healthcare workers who have even come in close contact, and neuro ICU, this lady was it, believe me. So apparently the policy is only if you are COVID positive and if you have symptoms, then you'll quarantine. Forget the high risk contacts. So we are still in a dilemma. But what I was referring to, Ajit, is what you and I have discussed. My colleagues, not just I, my colleagues and we have always been very clear, my neurology, HOD, psychiatric colleagues, other management, and say anyone who feels the need to avail of leave or quarantine, please be my guest. We will respect your subjective feeling, 1. 2, never any issue about PPE. Come what may, come hell or high water, my job is first to make sure that adequate PPE is available. And even if the level required is level 2, somebody says, I want to use level 3 PPE, please be my guest. So that flexibility, and as you said, Ajit, for people to feel that you are cared for, and the teamwork.
Names of COVID positives are not being revealed. Whereas when it comes to healthcare professionals, they are coming out openly and revealing themselves. So why is this stigma, so much stigma in India? It's not there in UK or US.
No.
It's not there in UK. It's not there. They reveal the names.
What?
They reveal the names, so they'll know who is positive, who is not positive. But here, they're coded. The names of COVID positives are coded.
Okay, sorry, I misunderstood. I don't know about UK, so I can't answer that really. I think there's a need for some degree of privacy and confidentiality. So I don't think it should be mandatory to reveal it straight away, but people at risk must be warned.
Oh yeah, oh absolutely, totally. I can't agree more. Proper warning, all facilities and support offered, and now by current policy, choice is yours.
But why is the stigma, so much stigma?
Oh, that. Vijay, I don't know why you're surprised, my friend. From plague to leprosy to tuberculosis to HIV/AIDS to now. Varying degrees of stigma for something that's new, something that requires, that induces fear, including mentally ill persons. See, the stigma is essentially about my fear about what will happen to me. So to me, it's fairly simple, if I may say, that wherever there is the fear for oneself or for the society's safety that society perceives, there will be that stigma. I think COVID stigma will die down soon, at least unlike HIV and all that took so long.
There are two things that go with stigma: ugliness and death. If these two associations are there, there is stigma. That's why there is not much stigma associated with rheumatism, for instance. So there is ugliness in epilepsy, there is ugliness in leprosy. So forgive my using this word, no offense meant to people who suffer from these conditions, but there is a certain degree of, hey, I can't bear to look at him, I can't bear to see this. That kind of feeling is there, and then stigma attains on that. The other thing is death. Because COVID is a potentially lethal illness, I could get it. Hey, I want to avoid this. That is, stigma leads to exclusion, or exclusion leads to stigma is a question that a debate that goes on, but I think they're not that different. There is a question over here, Vijay, that says, Ajit sir, are we vendors of hope? Alvika has asked this question twice. Can I take that up?
Yeah. You can see that. Yeah, Malvika.
So
Yes, sir.
I like the idea, but I don't like the phraseology over here. So forgive my thorough personality over here. So, Mahesh, thanks for that compliment. I take it as a compliment. We are not vendors of hope, but certainly we ought to be instillers of hope. As mental health professionals, it is our job across the board, not only in the context of COVID, but generally we should be instillers of hope.
There was an anonymous attendee question on the Q&A. What we have discussed in the previous webinar also, and my hobby was, how much should we test and when should we test for COVID status in homeless? Of course, the person used the word wandering, which I don't prefer by now. Wandering mentally ill persons. Allow me to again share that the case that we found last night positive and passed away this morning was in the hospital for 3 weeks, as I said, 2 previous tests negative. 3rd test positive. So this is there is no final gainsaying as yet. But what we generally tend to do is between 9th or 6th and 7th to 14th day, definitely 1, if you like 2 tests. In this particular case, I mean, there were reasons for which we did the 3rd one. And lo and behold, we found that positive after 2 negatives.
Sir, 6th day from when? 6th day from when?
See, that's the problem, Vijay, in terms of homeless, destitute persons. 6th day, one might say from the last contact. You know, for our staff, when we say we calculate from the last proximate contact with the COVID positive person, you know, to the extent known. So we take it, if we don't know the history, then at least after admission, from the time we have observed. Besides monitoring for symptoms, flu-like illness, you know, at the screening and every day or morning, evening, I guess for homeless destitute where we don't have background history, from the day of admission.
There's a question to Dr. Bide. I'm not sure whether this is answered. Could you please elaborate on how to offer help to medical professionals in a way that are not explicitly mental health services?
We dealt with it. I said,
okay.
There's another question from Vasudha, which says you have rightly pointed out burnout levels and high burnout levels in doctors even before the pandemic. We are seeing lots of young doctors dying nowadays due to lifestyle reasons. How should we help circumvent the reluctance to speak to mental health professionals? I think this is really a very important question, but beyond the scope of today's discussion. I think we should, Mahesh, I'm inviting myself for another Arogya symposium on...
Done, sir. Done.
That's a good idea.
Burnout is a terribly important, I use the word terribly, I think subconsciously, but very
yes.
phenomenon among doctors, really.
Yeah.
There's also one question from Dr. Aninda. What is the common clinical picture seen in patients of IBHAS? Is it fear of pandemic or people facing problems?
Yeah, I answered that. See, in the routine psychiatry emergency OPD, the profile as of now remains the same as it was. I mean, except for occasional cases of acute stress disorder. So this whole need that we seem to have, I mean, if I might say, we are looking for cases that must come and tell us, I am because of lockdown or I am because of epidemic. Maybe it will happen in next few weeks or months. But I don't know of any mental health center that has really data on that. The routine services continue, maybe with a bit of a different flair.
There's another question from Manoj Kumar. In case of relapse cases, is there any strategy to stabilize them in the community?
Yeah, that's, I think my faculty colleague again, and which is wonderful. See, as many of us will know, the British model of assertive home-based program, right, or assertive outreach, Australia, New Zealand, Canada, UK, the time that our DMHP can reach, or in fact, what I saw, Mahesh, you have started.
Yeah. Yes, sir. Yes, sir.
Mahesh, what do you say? Why don't you describe that? But how feasible is it for the public sector, for masses? Please.
Sir, in terms of the cost, if you can keep it bare minimum, I think it's still doable, sir. Right now, whatever cost we are offering, I don't think people will have a complaint about the way we have planned it, sir.
But would that be, fair enough, Ash, would that be upscalable to, let's say, as part of DMHP? That's the question.
Ultimately, if you can't reach the patient who needs the services at home and who's not ready to come, I think the whole purpose is still defeated, sir.
Because no, most of them that's wonderful. Sorry, go on.
Most of them are unwilling, and we have taken it to the grassroots level of catering to the patients, sir. Either it's through teleconferencing, video conferencing, or it has to be an actual visit to make sure the compliance visits are ensured, sir. We've also been bestowed with an additional responsibility with the courtesy of Mental Health Care Act. On discharge planning, the sure. Care planning is on the doctor.
No, I've been very impressed with what I saw of your invite and the program that you described. My only question is, because even in UK, and I've studied this to some extent, the apparently nice and lovable, almost lovable home-based care program that I've actually seen and been part of evaluation of sometimes, in major research by Tom Burns, did not prove value for money. So when you subject programs which are philosophically or heart-driven or philosophy-driven, if they don't stand the testimony of economics, and especially in a country like this. So my question, Mahesh, is more to you at that level. But I agree with Manoj, and Manoj, we've been discussing this enough amongst many niceties. Our DMHP will actually have to have that aftercare home-based program. And I'm sure if Nirmala is here, she will agree, But how workable is any one model or 5 or 10 different models of that going to be in this country is something that I am still very circumspect about.
Sir, I'll just try to add to this. When I spoke to Professor Naveen in NIMHANS, he mentioned some of the DMHPs have actually done home visits, and these are the home visits where some of these patients, maybe a person with schizophrenia or long-term enduring mental illness, when they miss their follow-ups, I think they arranged for the ASHA workers or other frontline grassroots level workers to go home and actually monitor them. And as part of 2 projects in Turvekere, I think in Tirthalli, I think they have been doing this, providing home visits, and especially for those who are missing the appointments, for who can come, they can come and collect, and they can take their injections or medications.
Vijay, Mahesh, don't get me wrong, any one of you, especially 2 of you, Ajit and I think we have been through this many times. See, demonstration projects work beautifully. Okay, many countries, especially here. Like I said, one is the upscalable nature to a country like this, and second, the economic evaluation. Those are my reasons for circumspection. Surely they must be tried. Demonstration projects have worked well, But that's another debate again. I mean, maybe post-COVID era, Mahesh and Vijay, maybe how do you stabilize post-treatment community-based care? Or as Nirmala would say, and I agree with her, community-based or family-based post-treatment care. How do you, with technology, with whatever else, how do you evolve workable programs for doing that?
Sir, whatever we propose right now, I think it's workable simply because 750 rupees for somebody to be evaluated at home and the feedback to go to the treating doctor is something doable, sir.
Sure, possible.
Possible, 750 rupees.
And running a hospital is expensive. Running a hospital is expensive.
1,250 rupees. With 1,250 rupees, the video consultation will be done with the patient, and the consultation is complete and dose is all altered to stabilize the patient at home, which is extremely viable for the patient, from patient point of view.
Possible. We must see.
It's not only for our hospital patient. Any psychiatrist can do that. That's an independent agency offering this sort of house visits, and these are trained people in mental health care, sir. So can I take the next question, sir?
So please.
How to handle and minimize negative perception about patients due to violence against professionals, and also denial of rental properties, denial of burial grounds or cremation. Such instances can bring down the professional morale. Dr. Bide.
I would like to say that everything is not in the realm of the medical person. We need good sociological inputs. We need good social training in our country. The gentleman who came and talked to us at the Bangalore ANSEPS, who I forget his reminds you, remember the Hindu editor on rural affairs who had psychosocial adversity? He has always been talking about farmer suicides, and he says, this is an economic problem. What are your mental health professionals doing over here? Lakshmi Vijay Kumar, of course, was up in arms against that kind of statement. But I think educating our public about what our public health needs is not only the medical person's domain. So the denial of burial or cremation or any other means of disposal of the dead is not really our province. We have to be there to say that, listen, by doing this, the infection is not going to spread. That much is our role. Beyond that, to get the public to agree to accommodate these people, accommodate these deceased people's bodies, is really a social welfare issue that needs to be handled by them. It's not our domain. The stigma we can handle, saying that there is the risk, this is the reason why you should not shun this person. That is our realm, very much. What is it? Before the burial and cremation, what was the other thing you asked?
Frankly, allow me. Frankly, I am with Ajit in what he's saying. Not only that train of thought for farmer suicide, that's very valid at one level. Of how, yeah, how the flawed economic policies then use psychiatrists and mental health people as go in between to say, why are they committing suicide? In fact, our teams have discussed this a lot in last 6 weeks, even about the assessment that we are doing in the shelter homes. While we are very happy to work at all 3 levels, as I said, identify and treat psychiatric disorders, identify and help with counseling those with psychological distress, and work for general positive mental health in those distressed people. We are very aware as teams, and we have had a lot of debate about, is there a role there? I mean, if the concerned government agencies had handled the migrant labor well, there would have been no need for the Supreme Court to say, we want counselors and psychologists who could go to shelter homes. So what Ajit is saying, I'm completely with that conceptual plane. We sometimes actually tend to get misused and used as a profession. Should we stop that? No, but be aware. Sorry.
The mind is everywhere. So they believe the psychiatrist must have a role everywhere. Nimesh, in the context of what you were saying, your presentation, this is one thing I wanted to say, that we are going to see massive changes in our social norms. Huge changes. Changes in lifestyle. I can foresee it. Within 2 years from now, we are going to be very differently attuned. And more than us, we are passing out, so to say. There are the younger people whose lifestyles are going to undergo changes that are very difficult to totally predict right now. And we are seeing economy of a different kind. We can, like I took the position on burial and cremation and say that this is not our realm. But young people looking at migrant labor, saying that these people are cut out just for this in the higher echelons of society, that's the attitude that is being imbibed. To say that this was not preventable is so foolish, and it tells on young minds, those who are very sensitive, who feel very bad about the migrant laborers. This man walked from Bombay to some Jogri Talaiya or Rajnandgaon. Sorry, I'm going to it badly. These people have walked these thousands of miles. It affects sensitive people a lot, and we have to try and see that these social maladies also reduce. It tells on mental health. Is it our job? Not quite.
Dr. Vijay, have you missed any questions from the chat?
I don't think so.
No, I think we have covered both Q&A and chat.
Yeah.
One thing I want to say is that the Spanish flu, so-called Spanish, you know why it was called Spanish? Because of the Spanish royalty were afflicted by it. It had very little else to do with Spain. The highest mortality was in India.
Yes.
Very few people are aware that the largest toll, amounting almost, I think, to a quarter of the mortality, was in India. I wouldn't be terribly surprised if in the long run, we again are if not on the top, close to the top, the way things are going in this country. Not to blame the healthcare services, not to blame shortcomings, but I think we have to be geared to a long-term problem that's going to be on our hands. We know that what happened with the first, the Spanish influenza pandemic was that the lockouts worked very well. The things are largely under control. And then at that stage, the World War came to an end. The Allies won.
Yes.
There was huge celebration across Europe. In the course of this huge celebration, the lockdown was completely forgotten. Quarantine was away with, and we had a second surge. And that second surge is what took the toll in the West. Meanwhile, what was happening in India was very different. There was no celebration for the end of the World War. We didn't have the need or the scope for it. But these are things that are foolishly done and which are quite preventable.
I'm so totally with you on that, Ajit, and I'm actually apprehensive about that. Let's wait and see. I agree completely.
Okay. Dr. Mahesh, any final comments, and you can wind up.
There's a last question I had to answer. I kept it in the last. Even after listening to Dr. Ajit, if somebody has a question why we compared him to Shashi Tharoor of IPS, I think there's definitely a comparison. If at all Dr. Shashi Tharoor can have a dialogue, and if there's any mistake, it's only Dr. Ajit who can correct his grammar mistakes and syntax. So he's the only one who can debate with him and put him to shame, is what I believe. So I rightly said he's Shashi Tharoor of IPS.
No. I'm nowhere near Shashi in this realm. Let me be clear about it. Incidentally, Shashi is my classmate's classmate. Many of you may be knowing Dr. Devanand, who's an outstanding researcher in Alzheimer's disease in New York. Devanand was my classmate in NIMHANS. He quit before the course because he had decided to go to the US. And Devanand's classmate was Shashi Tharoor. We went to meet him in his office when he was commissioner for refugees in the United Nations in New York. That was in 1987. Before you were born, Mahesh?
Yes, sir.
It must have rubbed off.
I think we'll with this we'll bring this to the close. Thank you very much, all participants. First of all, I have to thank all the participants, attendees. Because of them, we are able to run this program. Thank you, Dr. Ajit Bede. Thank you, Professor Nimesh Desai. Thanks, Dr. Mahesh. Thanks, Mr. Ganeshan, for supporting this cause. I'm sure it's a very useful, productive session. I'm sure a lot of people have got benefit out of it. Thank you, one and all. Good evening, good night, Shubhratri.
Big thank you. Good night.
And I think we have to let people, have some family time also, as we have mentioned earlier.
Yes.
So with this, thank you very much, everyone.
Saturday night fever.
Thank you.
Thank you, one and all. Good night.
Good night. Bye, folks.
Bye, sir.
I want to add